Welcome to our webinar, Understanding Glaucoma Diagnostics Exams. My name is Brizette Castellanos, and I am the Manager of Outreach and Social Media at Glaucoma Research Foundation. As you've probably heard, January is National Glaucoma Awareness Month. It is a good time to talk about this sight-stealing disease and raise awareness about the importance of regular eye examinations to preserve vision. So talk to your family and friends about glaucoma. Do your part and help spread the word. Joining us today is Dr. Danica J. Morelli. Dr. Morelli is a clinical professor at the University of Houston College of Optometry, where she serves as the Assistant Dean of Clinical Education and staffs the glaucoma, retina, and general eye disease clinics. In the classroom, Dr. Morelli teaches ocular pharmacology, glaucoma, and case-based learning courses. Dr. Morelli received her Doctor of Optometry degree from UHCO. She became a diplomat in the ocular disease section of the American Academy of Optometry in 2009 and is the vice president of the Optometric Glaucoma Society. After Dr. Morelli's presentation, we will be joined by a glaucoma patient for the Q&A portion of the program. Erica Shepard was diagnosed with iridocorneal endothelial syndrome in 2014, along with secondary angle closure glaucoma and Chandler's syndrome. She has undergone glaucoma shunt surgery twice and became a patient ambassador for My Eyes in 2023, which stemmed from her appreciation for home-based glaucoma monitoring and her passion to help others with glaucoma. Please welcome Dr. Morelli.
Thank you very much, Brizette, for the introduction. And I just want to start by saying how fortunate I feel to be invited to participate in this webinar. I spend a lot of my time talking to students and a fair amount of time talking to other doctors around the country about glaucoma, but it's pretty uncommon for me to get a chance to speak to a group of patients who have glaucoma, who have loved ones who have glaucoma, and it's a real privilege for me to be here. So I know that there are probably people joining the webinar who are very early in their glaucoma journey. They may not know a lot about glaucoma. And there are probably others who are on this webinar who are further along in their journey and may have a very good understanding of what glaucoma is. But I thought it would be worth just a couple of minutes talking about what is glaucoma so we're all on the same page. Glaucoma is a chronic, meaning it never goes away, it never ends, progressive, meaning it gets worse over time, disease of the optic nerve in the eye that causes irreversible vision loss. You know, the nerve tissue in our eye is very similar to spinal cord tissue or to brain tissue. And so if you think about a spinal cord injury or a brain injury following an accident or a stroke, when that damage occurs, we can't reverse it. So in glaucoma, when vision is lost, that vision loss is permanent. And so our goal is always to prevent further loss from occurring down the road. Glaucoma is usually associated with elevated intraocular pressure or eye pressure. I think it's easier to say eye pressure, so I'll say that today. It's not always the case, but generally it's associated with higher eye pressure. Our treatment of glaucoma is always geared towards stabilizing the disease and preventing further vision loss. I already said we can't get back what we've lost, but we can try really hard to keep further vision loss from occurring. All of the current treatments that we have for glaucoma today are aimed at lowering the eye pressure. And we can do that with a lot of different things. We have a lot of tools in our toolbox to treat glaucoma. Most glaucoma patients take at least one eye drop every day, sometimes multiple eye drops every day. Many glaucoma patients undergo laser treatments, and that can be done more than once. And some glaucoma patients also need surgery. And as Erica will talk about later on, sometimes you have to have multiple surgeries in order to control the pressure. But one of the things I want you to remember is that there is a direct link between lowering the eye pressure and slowing down or preventing further vision loss in glaucoma. So how is glaucoma detected? Glaucoma is sometimes called a sneaky thief of sight. Because unlike some other types of eye diseases, glaucoma doesn't really give you any warning symptoms. It doesn't make your vision blurry until very late in the process. It doesn't make your eyes red. It usually doesn't hurt. And so the only way that you know that you have glaucoma is to have a comprehensive eye exam. When you have your yearly eye exam, your doctor will ask questions that may raise some red flags or may identify some risk factors that you have that you might get glaucoma. And your eye doctor will also look inside your eye and look to see if he or she can see damage to the optic nerve in the back of the eye. Your eye doctor will also check your eye pressure, and that is something that can be identified as a risk factor for getting glaucoma. So because you don't have any symptoms early on, it's really important to have that yearly eye checkup. And I think it's especially important for those of you who are attending this webinar who have glaucoma to talk to your family members. I think Brizette said it in the introduction, but talk to your family members. There is a tendency for glaucoma to run in families. It's not entirely predictable, but all of your family members, if you have glaucoma, should be encouraged to have that comprehensive eye exam and to tell their eye doctor that they have a family member with glaucoma, because it does mean that they're a little more likely to get it themselves. So there's a variety of glaucoma testing that goes along with making the diagnosis and then following a glaucoma patient over time to see if the glaucoma is worsening. So sometimes you'll have your routine eye exam and your doctor may say to you, you have glaucoma. Not too many patients get that diagnosis right at the very first eye exam. A lot of times what happens is your eye doctor sees some things that are risk factors or that are suspicious for glaucoma, and they might call you a glaucoma suspect. I think that's a kind of a tricky spot to be in because you kind of have this worry, do I or do I not have glaucoma? But it's a really common place to be. Some patients it's very easy to tell that they have glaucoma, and some patients it's very easy to tell that they don't have glaucoma. And there's kind of a big range of people who might have one or two risk factors or who may have some subtle signs that we can't quite be sure this is glaucoma. And they end up getting tested as if they have glaucoma, looking to see if those things will ever materialize into a definite glaucoma diagnosis. So on the screen, you'll see a number of tests that I've written down. The ones that are in the box I'm going to talk about later. Those are the tests that are done more commonly. In fact, some of them are done at every single exam that you have once you've been identified as a glaucoma patient or as a glaucoma suspect. The top two are pretty quick. They're not performed very often, but I thought I'd go ahead and talk about them anyway. The first is examining the drainage system of the eye, which I'll explain in just a minute. And the second is measuring the thickness of the cornea. The eye is constantly producing a fluid inside the eye. Now, this is different from your tears, which are on the outside of your eye. This is a fluid inside the eyeball, and that fluid nourishes and provides oxygen to the internal structures of the eye. The eye is constantly producing this fluid, and then that fluid has to constantly drain away from the eye to make room for more fluid. The eye fluid drains in this little area of the eye called the drainage angle. We can't see that with the naked eye or with our microscopes unless we put a special lens on the eye that you see over in this right image. And that lens has a bunch of mirrors that help us peek into that drainage angle. Now, we usually do this test when we're suspicious that you have glaucoma to try to decide what type of glaucoma you may have. Does it look like the angle, that area of the eye that's draining the eye fluid is open, or is it closed? And so you may hear closed angle glaucoma or open angle glaucoma. This test, gonioscopy, allows us to investigate that. We sometimes repeat this test every year or two because there can be changes to the angle as a patient ages. Another test that we do typically only one time ever is to measure the thickness of the cornea. And in this picture, you'll see the doctor using a very simple device that gently touches the surface of the eye and measures the thickness of the cornea. Now, the cornea is the clear dome over the front of your eye where a contact lens would rest. The reason that we do this test, called pachymetry, is that if you have a very thick or a very thin cornea, the eye pressure readings that we get may be affected. So this doesn't really tell us if you have glaucoma or if you don't, but it gives us a little insight as to the pressure readings that we take at a different time during the exam. Now, one of the tests that you'll have every single time you go to the eye doctor is a test to measure the intraocular pressure, or the eye pressure. The image on the left comes from Glaucoma Research Foundation's website, and it's just a reminder that the eye is constantly producing and draining this fluid. And it's really the balance between the amount of fluid that's produced and the amount of fluid that's draining that creates a pressure inside the eye. I think the easiest way to think about this is to think about a kitchen sink or your bathtub. If you turn on the water in your kitchen sink or in your bathtub, but the drain is open, some fluid is going to build up in the bathtub or the sink, but some of it is going to be draining out the drain. And so you'll have this balance, and there's not going to be water that overflows onto your bathroom floor. But let's say you have a problem with that drain, and there's a clog in that drain in the bathtub, and the fluid is still being produced, it's coming out of the tap. Then in a bathtub or a sink, that sink is going to fill up and the fluid's going to spill over. Of course, in an eye, we don't have a place for that fluid to spill over if there's a problem in the drain. So the fluid builds up and the eye pressure builds up, and that can lead to glaucoma. So every time you go to the eye doctor, you're going to get your eye pressure checked. Now, sometimes you'll get this with a little puff of air, but a better way to measure the eye pressure is with this instrument right here. You'll see it in the picture. This is one of my optometry students who I asked to sit for so I could take a picture of this the other day. So it's a little probe that has a bright blue light, and it gently rests on the eye, and we're able to measure the eye pressure. A few things to talk about eye pressure. Normal, in quotation marks, meaning for the general public, normal eye pressure is typically somewhere between 10 and 21 or 22. But there's a wide range of variability. My father's normal eye pressure is about 9 millimeters of mercury. My normal eye pressure is about 14 millimeters of mercury. And my mom's normal eye pressure is about 19 millimeters of mercury. So we have very different pressures, but none of us has glaucoma. Not only does it vary from person to person, but our own individual eye pressure can vary a lot from the morning to the night. If you think about when you're going to your eye doctor, you're only going during the hours of maybe 9 and 4 or something in the afternoon. And so there may be times when your eye pressure is higher than it's being measured in the doctor's office. And so that's something that we always have to think about when we're looking at our patients. It's also important to remember that having higher than normal eye pressure, say you have an eye pressure of 23 or 24, it doesn't mean that you have glaucoma, but it does mean that you're a little higher risk of getting glaucoma. And the higher that eye pressure, the higher the risk. So if you have eye pressure in the 30s, for example, you have a much higher chance of getting glaucoma than someone whose pressure is 20, for example. The other thing to remember is that some people have what's called normal pressure or normal tension glaucoma. These are patients who have glaucoma, but we never measure a high pressure on them. And that represents a certain subset of patients that can be particularly challenging to treat. Your doctor may describe to you or may tell you a target pressure or a goal pressure that she wants to achieve with the different treatments that I mentioned before. So she may say to you, I would like for your pressure to consistently be under 14 or under 16 or whatever it is that your doctor has determined that they think is going to be a good pressure for you. I think patients can have a tendency to get a little bit overly concerned about very small differences from visit to visit. And it's important, again, to remember that we will have differences from day to day, from morning to evening, even with our treatment. So while we certainly would be concerned about eye pressure that's consistently higher than we want it to be, a single point or two higher than normal on a rare occasion is probably okay. Now, this is an image of a patient using a home tonometer or a home eye pressure measuring device. This is a relatively new technology that is available to kind of help identify those patients who maybe their eye pressure is pretty normal when they're in their eye doctor's office, but maybe late in the evening or early in the morning, the eye pressure is higher than that. Not everybody uses this technology. I think that Erica on our panel during the Q&A session has a particularly compelling story about her own personal experience with home tonometry readings. Again, not everyone uses this. And it's not appropriate for everyone, but for certain patients, this can give really important information about what's happening after hours, so to speak. I want to move to the next test that we do, and it's really not a single test, but a series of tests that we do that examine the structure of the optic nerve. So over on the right-hand side, you'll see a number of drawings of optic nerves. So I want to focus on the one that's up and to the left. This is a typical looking optic nerve. It always reminds me of a donut, and the donut part, the thick outer part of this, is the nerve tissue. And then there's a central depression that we call the cup. If we look at these pictures, as we increase, as we go down the picture list, that cup part, the depression in the middle, is getting bigger, and the donut part, the actual nerve tissue that we want to preserve, is getting thinner. And so we're looking at a patient's nerve getting worse and worse as they develop glaucoma. So we look at this structure consistently, constantly, almost every time you're coming in, to see if we're seeing signs of damage to that nerve. Sometimes it can be hard to determine if someone has just an unusual looking nerve or if they have a nerve that really has glaucoma. So oftentimes that's why a patient might become a glaucoma suspect, because they have what we call a suspicious looking nerve. And many times we will do additional tests to see if that nerve is really normal. We look at the nerve by doing ophthalmoscopy. That's a fancy word for the bright lights that we use. So here I am over here. I have this kind of funny looking instrument on my head that shines a bright light into a patient's eye. And then another, probably better way to look at the optic nerve is with a little lens that we hold very close to your eye when we're at the microscope. So we look very carefully at the structure of the nerve to see if we see changes that are consistent with glaucoma. Once we make a diagnosis of glaucoma, we continue to do this to see if the nerve appearance changes over time. Another test that we commonly do to objectively measure the optic nerve is called OCT. This is a simple, painless test. It doesn't puff your eye with air or do anything crazy. It just is able to objectively measure the thickness of the nerve. When we're trying to make the diagnosis of glaucoma, we utilize something that compares your thickness to other patients who don't have glaucoma to kind of see how your test results measure up. Once you have glaucoma, we repeat this test to see if we see any changes over time. These are two different OCT printouts. These are the reports that come from this instrument. And the one on the left, I really don't want you to pay attention to the bottom stuff. I want you to pay attention to these bright blue boxes. And so if we look in the middle of this box, we see this gray circle, kind of looks like a donut. That's our optic nerve. And what we see are these bright yellows and reds that are coming from the optic nerve in a very characteristic kind of a butterfly wing pattern. This is a normal OCT. This is a patient who does not have glaucoma. If we move over to the right, though, we've done the same test. We still see we have this donut here in the middle, but we're missing those bright reds and yellows where we should have these optic nerve fibers. And so this is a patient with pretty advanced glaucoma. So we look at this test to see how does this look compared to what it should look, how a normal OCT would look. And then once you're diagnosed with glaucoma, we look to see if it's changing over time. Another way to look at the structure of the eye is to take photography. We usually do this once every year or two, sometimes a little longer than that. And so I love to get pictures of my patient's optic nerves at the very beginning so I can see over time if there's been any structural change. One of the things that I like to explain to my patients is that we're always looking at the structure of the eye. We're looking at the nerve to see if we see any visible signs of glaucoma. And then we're also looking at the function of the vision. And I'm about to get into that. But the analogy I like to use there is when you take your car to the shop for an inspection. So the mechanic comes to you and they say, you know, I can see that your brake pads are getting thin, they're getting worn. And you say to your mechanic, well, my car seems to be driving just fine and I can brake just fine. And the mechanic says, I know, I agree with you. I got in your car, I drove it around, the brakes seem to be working fine, but I can see when I look at them that they're starting to thin. And if we don't do something about this, ultimately you're not going to be able to stop your car. In glaucoma, sometimes we can see the changes when we look at the optic nerve before we can see any functional problems with your vision. So we do these tests, the ophthalmoscopy, the OCT, and the photography to try to see glaucoma at its earliest stages. Ultimately, though, we really want to know what's going on with your vision. Now, if you ask someone who hasn't had glaucoma testing, how's your vision? They might say something like, oh, my vision is 20/20. Or they might tell you, I can read the smallest letters on the eye chart. And that's important. That's your visual acuity. And that's our finest, most central vision. But that only tells a small part of the story of our vision. We have a lot of peripheral vision that's really important. Our central vision is important for things like reading and detailed work and recognizing faces and working on the computer. But our peripheral vision is really important for lots of other things that we do. It's important for walking around and not tripping over a curb. It's important for being able to see where your golf ball went. It's important for being able to play the piano or see what's going on in your environment. So it's not just about how far you can read down the chart. Now, this is a picture of my student, again, taking a test that we do pretty frequently in glaucoma suspects and in glaucoma patients. It's called a visual field. And my guess is if we were all sitting in a room together, I would hear an audible gasp or sigh or groan, or maybe a few curse words when you see this picture. And the reason is that no one really enjoys taking this test. But it's a very important test to tell us what's going on in your vision beyond how far down on the chart you can read. So this instrument measures your vision across your visual field. It has predetermined points in your vision that it presents a very brief light. Some of those lights are very bright and easy to see. Some of the lights are pretty dim and hard to see. And some of the lights are so dim that nobody can see them. One of the things I think people don't understand is that you're not really supposed to see every single light that this instrument shows you during the test. Patients tend to have a lot of anxiety about this test. They're worried about their performance on this test. But I want to reassure you a couple of things. One, the machine is really smart. And so if you give an answer that seems out of the ordinary, the test is going to go back to that point and it's going to test again. I sit down at this instrument and take it every once in a while, partly for screening and partly to remind myself what my patients go through. And I don't like it either. But sometimes I'll find myself sitting in the test thinking, oh, I think I saw it, but I might have blinked. And then I have to remind myself, don't worry, the instrument's going to go back and recheck that again. So if I could, sort of relieve a little bit of your anxiety about this test and just encourage you to do the best that you can, hopefully that's helpful in your glaucoma care. Now, this test compares our responses at every one of the points that it tests to what a typical response for our age would be, and it can show us where a patient's vision is not quite where we expect it to be. It can also be used to show changes in our visual field over time. Now, generally, we do this test about twice a year. We might do it a little bit more frequently in the beginning of a glaucoma journey, and we might do it a little less frequently once we realize that your glaucoma is pretty stable. So what does a normal visual field look like, and what am I looking for when this piece of paper spits out of the instrument? These are actually my visual fields. On the right side is my right eye's visual field. On the left side is my left eye's visual field. And I really want you to concentrate on this part right here that I'm circling with the red laser. You'll notice that I have a little black spot in my left eye and in my right eye. Anywhere where we see dark tones, gray, dark gray areas, or black areas on this visual field, it means that we're not seeing the very bright lights. Every one of us has a normal blind spot in each eye. And so those two kind of black spots that you're seeing in my visual field are perfectly normal. So what happens in glaucoma? Glaucoma slowly takes away some of your visual field. If we look at this top left image, this patient has a little bit of graying up here at the top of their vision, a little bit of worsening of the vision on the nasal side of their visual field. But if we look at some of these others, you see much deeper, bigger areas of blacker tones. That means that this vision is much worse. This patient, for example, who has vision loss in the top part of their vision might bump their head or hit their head on a cabinet door that's been left open by accident. We can have vision loss in the top part of our vision like we have here. We can have vision loss in the bottom part of our vision like we have here. Patients with vision loss in the bottom part of their visual field have more trouble with falls and tripping on things that they might not see on the floor. And then even though we talk about glaucoma taking away our peripheral vision, there are some patients who glaucoma attacks the central vision first, like we see right here. So these are a variety of different ways that a patient's visual field might look. We can use the visual field information to determine what stage is your glaucoma. Early glaucoma doesn't have any visual field loss. So this would be, if we go back to our brake analogy, where the car is stopping just fine, but the mechanic can see that there's a problem with the brakes. This would be a stage of glaucoma where we can see the damage in the nerve, but it hasn't shown up yet in the visual field. This is actually a great time to get diagnosed with glaucoma, because if we can control it well, you might not go on to lose any vision or not much vision at all. Then if we have a moderate amount of vision loss just in the bottom or just in the top, but not affecting the central vision, that would be moderate glaucoma. And if we have a lot of vision loss, either in the top or the bottom, in both top and bottom, or if it's affecting our central vision, that would be considered advanced glaucoma. If your initial diagnosis of glaucoma comes when you're already in the advanced stages, you have a higher chance of losing vision than if we catch it in the early stages. The good news is we've come a long way in our diagnosis and treatment of glaucoma over the last 20 or 30 years, and most people do not go blind from glaucoma. It is an unfortunate reality for some, but if we can catch it early and treat it well, we hope to keep your vision. This is an example of a visual field in very late glaucoma, and you can see that on this test, almost all of that visual field is black, but you will notice that there is still some vision in the middle. Most glaucoma patients don't lose all of their vision and maintain some central vision. That's not true of everyone, but most glaucoma patients. So sometimes a glaucoma patient will ask me, they'll say, you tell me that I have lost all this vision, but I don't see it. I don't notice it. I think my vision is really good. Now, this is not my image. It's out of a book on visual fields, but it's a really good explanation of why our glaucoma patients don't necessarily recognize their visual field loss. The eye is only part of the equation in how we see. The eye receives the information and sends a signal back to the very back of our brain, to our visual processing center in our brain. Our brain is pretty clever And when parts of our vision are missing, sometimes our brain will sort of fill in for us what it expects to see. So if we look at this image, on the left-hand side, the photograph with the apartment building and a car coming toward us and a car turning and a person in the crosswalk, that is the real image that we're dealing with here. A patient with a normal visual field will see all of those things. But if we come over to the right, and this patient has some vision loss right in that area where the car is turning and the person is in the crosswalk, our brain will tend to fill that in and not see it as a black spot, but kind of just fill it in as the most logical part of what it would be. And so in this sort of example here, a patient with glaucoma might feel like they see the entire scene, but they're really missing the fact that there's a person in the crosswalk and a car turning in the intersection. So another question that glaucoma patients ask me a lot is, how come you do these tests so often? I feel like every time I come in, I have to sit in that dreadful visual field machine. The reason that we test so often is because there can be variability from test to test. So, some days you feel better than others. Some days you're more tired than others. That visual field test is done in a really dark room, and sometimes people actually fall asleep. And so there can be some variability from test to test. We don't want to make important medical decisions based off of just one test. So if we have a patient that looks like their glaucoma is getting worse on their visual field, we're going to bring that patient back and repeat that field and see if that worrisome area is still there, or was that just a bad day? And so the reason that we're repeating the test so often is to kind of confirm or deny our suspicions that the glaucoma is getting worse. So I want to show you a couple of examples of that. This is an example of 3 visual fields that were taken over about a 4-year period of time. This patient was diagnosed with glaucoma right here before he even had any visual field loss. He was started on medication, and he came back about a year later, and the visual field looks about the same. Unfortunately, he moved away. He didn't get a new eye doctor in the new town that he was in, and he stopped using his glaucoma medications. And when he came back about 3 years later, you can see that he had developed a lot of visual field loss over that period of time that he wasn't using his eye drops. We want to avoid that, right? This is pretty easy to see, but sometimes it's harder to see if a patient's visual field has gotten worse. And so the instrument that I told you is pretty smart has some very good software that will help us analyze what's happening to the visual field over time. So this is a patient who's had 5 visual fields, or received 5 of the visual fields, and we can see that the trend of this visual field is downward. This patient is losing vision, and we can kind of tell at what rate that patient is losing vision. Then if we add a new treatment, maybe this patient has laser, or maybe they have surgery, what we hope to see is that instead of going downward, that visual field stabilizes. Here's a patient who has a very stable visual field. The line is going straight across. So this patient is not losing vision over time. That's what we'd like to achieve in glaucoma. And we can look at the same thing with our OCT. Remember where those bright yellows and reds surrounding the optic nerve were considered healthy. This is an OCT of a patient who has a particularly curious problem. She has glaucoma in only one eye. And when we look at this over time in the eye that does not have glaucoma, where we see those nice big thick reds and yellows on the OCT, if we look at the trend over time of her visual field and of her OCT, there's no change. She doesn't have glaucoma in this eye. But unfortunately, if we look at her eye that had a very peculiar type of glaucoma, despite multiple eye doctors being involved and multiple treatments for her glaucoma, this eye progressed considerably over a long period of time. Now, her OCT showed a lot of progression. We can see that she started with thick yellows and reds and ended up without much nerve tissue at all. Fortunately for her, even though she had some development of vision loss, it wasn't particularly bad. And ultimately, we were able to stabilize her visual field and her OCT. So I hope this is helpful when sort of you're going to your eye doctor and you're thinking, oh, I don't want to do that test, or I have some anxiety about what these tests are going to show. Hopefully this is helpful and may give you some information that would spur you on to ask some good questions of your doctor. And I think with that, it's probably time for questions and answers.
Thank you, Danica. That was amazing. Thank you to everyone who submitted questions, and special thanks to our panelist, Erica, for joining us. Hi, Erica. Can you please start us off by introducing yourself and telling us a little bit about your journey with glaucoma?
Sure. First, I want to say thank you to Dr. Morelli, because that was, as a glaucoma patient, that was an incredible explanation of, we see the charts and we see the pictures, and just to be able to have some background and understand that a little bit better is so helpful. So thank you. So I've had glaucoma for about 10 years. I was diagnosed with something called ICE syndrome, and it's very rare. So it was a little tricky to find, but once we did, my glaucoma, we tried to control with drops. That didn't work. So I did have a shunt installed. And over time, the shunt failed, which was not a surprise to us just based on the nature of my disease. So I ended up renting a home tonometer about a year and a half ago. My pressures were going back up. They were in the 20s. And like Dr. Morelli alluded to, that wasn't actually too bad for me. So I rented a home tonometer just to see where my pressures were at other times during the day. And what we found is that my pressures were spiking into the 40s. So for, a situation where we thought we had some time to kind of figure out what the next shunt would be or the next step would be, we realized we had to do something pretty quickly. So the home tonometer for me literally saved my vision. So I did end up purchasing one, and I did end up working for My Eyes, which rents and sells them. So I'm very passionate about home tonometry and glaucoma, and we speak to patients every day. And it's just incredible to hear some of the stories.
Thank you so much for sharing. We've received a lot of questions, so we're gonna jump right in. First question we have here is, where can I go to get a comprehensive glaucoma test?
So I'll go ahead and take this question. Most people don't have glaucoma, right? And so that first chance at deciding whether or not you have glaucoma or whether you're a glaucoma suspect is to have that comprehensive exam. This can be done by an optometrist or by an ophthalmologist. This is not something that you would do at your primary care doctor. Like sometimes your primary care doctor might have you read the eye chart, cover an eye and read the eye chart. That's not what we're talking about. We're talking about an eye exam that checks your vision, that checks your eye pressure, and where the doctor looks inside the eye with one of those bright lights that I showed you and carefully evaluates the nerve. Every comprehensive eye exam is, in a sense, a screening for glaucoma. So really any eye doctor can do this test.
Thank you for that. We have a question here about insurance. Does insurance cover glaucoma testing?
It's a bit of a loaded question. So eye insurance is a little bit unusual. Some people have what we call vision insurance, and vision insurance will cover a kind of a routine exam and maybe pay some towards your eyeglasses or contact lenses if you need it. It will not cover any special testing, but still it will cover that kind of comprehensive exam that I was just talking about. Medical insurance, every panel or every insurance company is a little bit different. Some will cover one comprehensive eye exam per year. Some will not cover an eye exam in terms of your coverage. But once you have a diagnosis of glaucoma or glaucoma suspect, or ocular hypertension, which is just a fancy word for saying your eye pressure is high, then it becomes a medical problem, and all medical insurance will cover this type of exam. There's one other thing that gets covered that is worth mentioning, and that's for patients who have Medicare. So patients who are over 65 who are enrolled in Medicare, if you have certain risk factors, you can get a glaucoma screening covered by your Medicare.
Great, thank you for that.
Sure.
This question is for Erica. How accurate are home tonometers, and how available and affordable are they?
So, as far as accuracy goes, and I think Dr. Morelli can speak to this as well. She uses one I mentioned she uses one in her office. I've taken mine to my glaucoma specialist, some of my other specialists, and mine always run within a point or two of the Goldman. So they're very accurate. The one thing to remember as well is that the home tonometer can check for fluctuations as well. So you're looking for patterns in the IOP, whether it's a spike or whether it's a dip, or just a big fluctuation, which can also be dangerous. They're available from a few distributors in the United States. Eye Care makes the Home 2 tonometer, and there's 3 or 4 of us that distribute it. I work for My Eyes. It's myeyes.net. You can rent a home tonometer. It costs about $250 a week to rent. And again, during that rental period, what people do is they check their IOPs at different times of the day. So they check it first thing in the morning, before they would typically get up, which it tends to be a high spike. For me, it tends to be at night, late at night, 9, 10 o'clock at night. That's when mine tends to spike. But what happens is all that data is collected over a week's time. And then the patient gets a report of what those pressures were, and the doctor gets a report of what those pressures were. They come back together and can make some decisions about therapies and drops. Do we need to change the time of day, frequency, that type of thing? To purchase a home tonometer, it is about $3,000. It's an investment for sure, but we are finding more and more insurance companies are paying for it. Medicare does not right now, but some of the supplement plans do. And at My Eyes, we give the patients everything they need to submit a claim. So the claim form, they're a copy of their prescription. You do need a prescription to get this. The prescription is really just a simple form that the doctor fills out online, and that's submitted to us. It is a medical device, so that's why you do need a prescription for it. But yeah, we're finding more insurances will pay for it for both the rental and for the purchase. So we encourage people to call their insurance companies and ask.
And I would add to that, I think Erica said something so important. I hope it didn't get lost. She said that when she takes her home tonometer to the eye doctor with her, to her glaucoma specialist, it's within a point or two. I think that the home tonometer is not looking for a point or two, right? That for our purposes would be really accurate. And these home tonometers, if the patient is able to use them, not everybody can get trained to use them, but most people can. We're not looking for, oh gosh, it was 14 and it's supposed to be 13. We're looking for exactly what happened to Erica, which is we thought my pressure was 20, but it was really 40, or it was really 35. Those are the kinds of things that we're trying to detect with the home tonometer, not little teeny tiny variances between one reading and the next.
That's a
great point. And the other thing is that when you do have a home tonometer, whether you rent it or purchase it, there's different activities. We have a lot of patients through My Eyes that we have hikers and divers and yoga, yogis and all kinds of different people, and they do all different activities. So they can use this device to figure out what raises my IOP and what lowers my IOP.
Yeah, another excellent point. Thank you both. Another question about home tonometers. Do you have any recommendations?
The Home 2, I would recommend, and I would recommend you go to myeyes.net. I will say that at My Eyes, all of our patient ambassadors like myself, we're all glaucoma patients. We all own a Home 2. We all have very similar stories to probably everybody listening to this podcast. So yeah, check it out, myeyes.net. There are other companies out there, but I would just encourage people to go where you're going to have that service and you're going to have that personalized, all your questions answered.
Thank you. Our next question is, what are the beginning signs of glaucoma you can test for at home?
I wish I had a fantastic tool for you to use at home. I think, as I covered in the presentation, only a very small subset of glaucoma patients has symptoms early on, and so there's not really anything to do. And in fact, having a home tonometer, if you don't have glaucoma, is probably not a useful tool. There's really not a substitute for that comprehensive eye exam. That's what makes glaucoma so tricky. And kind of, I think the saddest part of my work life is when a patient just hasn't had one of those comprehensive eye exams and they come in and they already have, pretty significant glaucoma, because then we're a little behind in trying to control their disease.
What are the challenges of detecting something like normal tension glaucoma?
Normal tension glaucoma probably makes up about 25% of open angle glaucoma. So that drainage angle is open, but the eye pressure, we never measure it very high. So the challenges in making that diagnosis are sometimes it's not on our radar, because one of the things that we really look for in glaucoma patients is that they have a high pressure. And so if we're just doing a routine exam and the pressure is pretty normal, maybe we don't look quite as carefully at that optic nerve because it's not on our radar. The other thing that we have to think about is that there can be some things that mimic glaucoma. And so we kind of have to do sometimes a few additional tests than we would normally do for glaucoma with high pressure. And then finally, I actually think that normal tension glaucoma is a great indicator to use a home tonometer, because sometimes we think it's normal pressure glaucoma, normal tension glaucoma, but if we checked the pressure at 10 o'clock at night, or if we checked the pressure at 5 in the morning, we might find that it's actually higher. And that's really helpful to know, because it might influence what we set our target pressure to be. And so there's a little bit of challenge in the diagnostic side, and then there are challenges in the management side too. If someone has an eye pressure that's really high, let's say 35 millimeters of mercury, almost anything that we do is going to have a significant impact in lowering that eye pressure. It's pretty easy to lower a pressure of 35. We have a lot of room to lower it down. But let's say we have a patient who is having glaucoma and their eye pressure 17, there's just less room for us to lower that pressure down, whether it be with eye drops or laser or surgery. And oftentimes surgery is the better way to lower pressure if the starting pressure is pretty low to start off with.
As a follow-up to that question, is circulation, obstruction in vascular system looked at routinely in normal pressure glaucoma?
It's probably not looked at routinely, in that if I think I have a patient who has normal tension glaucoma, I'm not necessarily sending them to have circulation studies or anything like that. We certainly know that people who have some circulatory problems, so things that come to mind are patients with migraine, so their blood vessels spasm and some parts of their bodies aren't getting enough blood flow. Patients who have a condition called Raynaud's syndrome, where they get kind of blue fingers and toes in cold weather or in cold rooms. Those patients have problems with the way that their blood vessels constrict and dilate, and those patients are more likely to get normal tension glaucoma. But it doesn't really impact how we're going to treat the normal tension glaucoma. So I would say that we don't often add additional testing related to vasculature.
Thank you. And this question, I believe, can be answered by both of you. So what questions should I ask my eye doctor after performing these tests?
Erica, would you start?
So anybody with glaucoma, or if you've had it for a period of time, you go and you sit in the chair and you look at the blue light and you hold your breath, but don't hold your breath because you're not supposed to hold your breath. But it really can be very anxiety driven because you may not have been in for 2 months, 3 months, 6 months, and you're waiting to see what that number is. So the number one question is, what's my number? So, that, and what does it compare to last time? If you don't remember what your pressure was the last time you were there, certainly, like Dr. Morelli alluded to, looking at your visual field. Have there been any changes in your visual field? Have there been any changes in the optic nerve? What does that look like? How am I progressing? The other thing I would say is not a question, but more feedback, is to make sure you're giving your doctor feedback about any side effects that you're having with medications, any other side effects that you're having, whether you're having floaters and usually you're asked those questions, but I just think it's really important to pay attention to even little changes, because little changes can be big things down the road. So again, and I alluded to activities that lower or raise IOP, that's always a great thing to ask as well. And then where you can get more information, the Glaucoma Research Foundation is a great place to start. So the doctors will have just a plethora of information and places that you can go to find any answers that you're looking for.
Erica, I heard the pharmacist in you coming out in your answer. And I think it's so good to bring up problems that you may be having with your medication, whether it be, poor tolerability. This drop is making my eyes too red or burn too much, or it stings too much when I put it in, or it's too expensive for me. Is there an alternative that I can use? Those kinds of things, being open with your doctor, are so important, and sharing that information. And I would add, when your doctor talks to you about how are you using your glaucoma medications, it's so important for you to be truthful about how you're using your glaucoma medication. Because look, I know that no one is perfect with their eye drops. There's not a single person in the world who's 100% perfect using their eye drops. But if I have faulty information about how you're using your eye drops, I'm going to make faulty decisions. So if I see that your glaucoma has gotten worse, and I'm under the impression that you're using your drops every day like I've asked you to, but in truth, you haven't been using them for several months, that's really important for me to know. Because if the problem is that you're not using the treatment that we've already prescribed, not that medicine's not working, it's going to help me make better decisions. And so being honest and truthful with your doctor about challenges that you're having with your medical therapy is really important. It's also really important to recognize that the doctor has a role in the management of your glaucoma, and you have a super important role. I can't come to your house every night and put your eye drops in. I can't check your eye pressure every single day. I can't, do the things that I'm asking you to do. I can see you once every 3 or 4 or 6 months and check your eye pressure and run a visual field and tell you how you're doing. But you have the most control over your glaucoma and what happens with it.
And we have a comment here that says, my doctor rarely discusses my results with me. So as a follow-up to that question is, am I able to ask for a printout of them?
Absolutely, you can ask for a printout of your test results. Now, I will say, as a doctor, there's a lot of subtlety that I'm looking for that I wouldn't necessarily expect a patient to be able to, understand everything that they're seeing. But I would also say to you, and I know doctors are busy and they have a lot of patients waiting and they have families and want to get home too, but your doctor has a responsibility to answer your questions. And so I think that establishing that communication and that dialogue is really important. But yes, you do have a right to ask to see your test or to have a copy of your test results. Sometimes it's not so easy to print them out right that second. They may have to send them to you through a portal or something like that. But absolutely, you have a right to your test results.
Thank you. How often should glaucoma patients or suspects be taking these tests?
It really depends on a number of factors. So let's take the OCT, that image that gives us those pretty colorful pictures of the nerve. We generally will do those tests about twice a year, sometimes once a year, but about twice a year in early to moderate glaucoma. Once a patient reaches the later stages of glaucoma, that particular test doesn't give us very much information anymore. And so we might stop doing that test altogether and rely more on the visual field. Most of the time, visual fields are done about twice a year, but there would be a time when I might do it more often than that. Let's say it's time, your 6-month visit, it's time to do a visual field, and it looks like your visual field's gotten a little bit worse. I want to confirm that suspicion that the test is getting worse, but I don't want to wait 6 months to do it. So I might have you back in 3 months that time. If everything looks like, oh, that was just a false alarm, it's not really getting worse, then I would probably go back to, say, 6 months. If you've had glaucoma for a very long time, and particularly after surgery, if they're able to achieve very low pressure and the glaucoma seems very stable, you might get to a point where they're only doing that visual field test once a year. The other thing that plays a role in how often we do these tests is the severity of your glaucoma. If you're a suspect, it's unlikely that you'll have the test done more than once a year. If you have mild to moderate glaucoma, you might have it twice a year. If you have severe glaucoma, you might need to have your pressure checked every 3 months, for example. So the worse your glaucoma is, the more often you're likely to be seen.
So there's two follow-ups to this. Oh, actually one. Should I get tested more if I have a family member with glaucoma?
The general answer is no. If you're having a yearly comprehensive exam, your doctor knows that you have a family member with glaucoma, and they don't see any signs that you have glaucoma, there's probably not a lot of value in having that routine exam more often. But if your doctor decides that you do have some, additional risk factors or things are a little suspicious, then you may need to be seen more than that yearly exam.
Got it. Thank you. Have home tonometers gotten easier to use? I tried to use it 2 years ago and very frustrating to get it aligned properly. That was one of the questions.
Erica.
2 years ago, the machine that was out was a little bit different. It was kind of the first model, if you will. The one now, there's a video on myeyes.net if you want to check that out. Very simple. I have mine here. Literally, you turn it on, you hold it up, and you can take your reading. There we go. And it downloads to your phone. There's an app on your phone. It downloads to your phone in about 10 to 15 seconds. And the great thing about it is there are charts and graphs and all kinds of fun stuff on the eye care clinic website that you can, once you have your readings in there and your readings are done daily, or if you're doing them weekly, however you're doing them, you can go in and track, and you can see trends, you can see fluctuations, your high, your low, your average. So I find them very easy to use. I mean, we have patients of all ages. We have pediatric patients that use them, and we have patients well advanced in age that use them too. And a lot of times we're walking them through how to use it over the phone. So, whether you're a technical person or not, I've found that it is easy. This, again, as Dr. Morelli said, it's not for everybody. If you have severe vision loss, there are still ways to get measurements, but it can be a little more challenging to see the ring inside. But go and watch the video. It's pretty cool.
Thank you. How does the time of day affect IOP readings? And should we schedule appointments for the same time of day or vary?
I love this question. So it depends on where you are in the process. So when I have a patient that I think has glaucoma, or even a patient that I've said you do have glaucoma, and I'm trying to figure out what I want their target eye pressure to be, I actually want to see them at different times of day, because I want to know, is their pressure highest in the morning? Is it highest in the afternoon? Now, I'm not using a lot of home tonometry at that stage, right? But I want to see them at different times of the day. Generally, though, once I start treating them, I kind of want to see them at roughly the same time, because I don't want, if I know, for example, that their eye pressure is higher in the morning, if I'm seeing them sometimes in the afternoon and sometimes in the morning, it's going to be a little harder for me to assess whether or not that medication is working.
That's a very good point. Well, that concludes our portion of the Q&A. Thank you both for making the time to be with us today and for providing such helpful information to glaucoma patients and family members and friends. Thank you once again for being here with us and for joining us in our bold vision of a future free from glaucoma. Because of your continued partnership, the cure is truly in sight.